Welcome everybody to the orientation for the Population Science and Policy Streamer in the Internal Medicine Clerkship. In internal medicine, the topic of population science that we will be discussing and we will be evaluating is value in healthcare. So what is value in healthcare? We think about value in healthcare as patient satisfaction. We also consider provider experience. We think about patient outcomes. And ultimately, we also think about the cost to the patient, the healthcare system, and insurance. So to give you an idea of the difficulty of value in healthcare as compared to other industries, if healthcare was like banking, ATMs would take days or longer as a result of unavailable or misplaced records. If healthcare was like home building, carpenters, electricians, and plumbers would each work with different blueprints and very little coordination. If healthcare was like shopping, product prices would not be posted. Prices charged would vary widely within the store, depending on the source of payment. So, I would like you guys to do a pre-clerkship survey. Please scan this QR code, stop the video, and complete the survey. Once you've completed the survey, please restart the video to watch the remainder. Okay, so if we're looking at the health system science wheel, you can see value in healthcare is here in the blue, light blue on the pie chart. And in internal medicine, we are focused on value in healthcare. So if we are defining value in healthcare, we want healthcare to be safe. Safe meaning that we are avoiding injuries to patients and also eliminating medical errors. We want it to be timely. We want to reduce our wait times and harmful delays. That needs to be a priority. Access to care should be as expeditious as possible. We want healthcare to be effective. We should be providing the most up-to-date and evidence-based services. We want it to be efficient. We should be avoiding duplication and waste of equipment, supplies, and other resources. It should be equitable. Healthcare to all patients should be provided without prejudice and regardless of individual characteristics such as gender, ethnicity, socioeconomic status, geographical location, or sexual orientation. And healthcare should be patient-centered. We should center the care around the patient and the patient's decisions, ensuring their preferences and values are accounted for in each step of care. So how do we assess value in healthcare? We look at outcomes. We look at patient outcomes, and we look at that at both the individual level as well as the systems level. We look at patient safety. We look at service. This is where those surveys come into play, patient satisfaction versus the patient experience. And we look at the cost of care. So the steps for promoting high-value care are intertwined with evidence-based medicine. So step one, we really need to understand the risks, the benefits, and the costs of particular interventions. Step two, we need to decrease interventions of minimal to no value. Step three, we need to choose interventions that maximize value. Step four, we need to create a plan that incorporates the patient's values and concerns. And step five, we need to identify system-level opportunities to provide value of care. Potential barriers to high-value care occur both at a systems level and an individual provider level. At a systems level, there may be lack of guidelines for a particular intervention for a particular disease, sometimes because there is lack of evidence. On an individual provider level, they may have poor familiarity with guidelines. On a systems level, there may be time pressure, emphasis on shorter visits, length of stay, productivity. I deal with this frequently as a hospitalist. On an individual provider level, there's lack of time to explain to patients, and patient expectations of care can sometimes get in the way of providing high-value care. On a systems level, we may have lack of centrally available information on prior tests. On an individual level, there may be discomfort with diagnostic uncertainty such that the individual provider may order a flurry of unnecessary testing. Local culture comes into play on a systems level. And on an individual provider level, there may be lack of appreciation of harms or lack of knowledge of costs for particular testing or treatments. And across the board, both on a systems level and an individual provider level, many individuals and systems, we are practicing defensive medicine in an attempt to not be sued for our care. So the Choosing Wisely campaign is a combined campaign between the American Board of Internal Medicine, Society of Hospital Medicine, Society of General Internal Medicine, and American College of Physicians, trying to reduce waste in healthcare. So a couple of examples on here. So there is an article from the Society of Hospital Medicine as a guideline or a recommendation to not order daily chest radiographs in hospitalized patients unless there are specific clinical indications. So patients may be getting daily chest x-ray if they are in the ICU and they have been intubated in order to ensure that the endotracheal tube is in the right position. Sometimes those chest x-rays get ordered as a daily order such that no one is paying attention, that the order is continuing even though the patient has been extubated and has been downgraded into a general level of care. So ordering daily chest x-rays doesn't make sense at that point, and it's adding to the cost of care. Additional lists of recommendations per society can be found within the Choosing Wisely campaign. So you can see American Society of Consultant Pharmacists are recommending to not use particular inhibitors or inducers with direct oral anticoagulants, to not prescribe tramadol for older adults, to not combine opioids with benzodiazepines or gabapentinoids to treat pain in older adults, and reevaluate routinely for deprescribing during chronic use. All good recommendations. So local culture is a barrier. What would that problem be? Well, sometimes that art of medicine often outweighs the evidence. The majority of our patients would be excluded from clinical trials if the art of medicine took precedence with all providers. When we talk about system one thinking, which is pattern recognition, if that goes unchecked by system two thinking, which is deliberate reasoning under certain conditions, such as time pressure, work intensity, and psychological stress. To give you an example of what system one versus system two thinking is, there was a patient that I took over their care, and the patient had come in with anasarca. He was elderly and was treated for heart failure exacerbation, and so was getting diuresed fairly aggressively in order to try and reduce his volume overload. However, the echo came back that did not show any evidence of heart failure. However, the team was continuing to treat him for heart failure when in fact he had nephrotic syndrome. So the system one pattern recognition went unchecked, and even in the face of evidence to the contrary of his having a heart failure exacerbation, he was still being treated and diagnosed as a heart failure exacerbation. That is when pattern recognition goes unchecked by deliberate reasoning, utilizing the data that you have. Local culture can be deeply ingrained and difficult to change, but that doesn't mean it's impossible to change. A barrier to high value care may be the hidden curriculum. If you have not heard of the hidden curriculum, what is it? It's nonverbal messaging transmitted on the job through practices, habits, and hierarchy. So often there may be senior physicians who influence the behavior of students regardless of what is formally taught, just by their attitudes and the way that they practice medicine. So in medical school, you guys are taught that the history and physical exam are key to diagnosis, which is true. However, some consultants request imaging before even evaluating patient at the bedside. I suspect that you will see this happen in practice over this coming year. Fear of disapproval can often outweigh fear of uncertainty. So you as a learner may not feel like you can speak up if there is a decision made that you don't agree with or you think is not according to guidelines or what's been formally taught. And that is the hidden curriculum. So examples of PSP in internal medicine. If we're taking a look at outcomes and we look at it at a patient level, individual patient level, we're looking at decreased length of stay in hospital. At a population level, we're looking at decreased readmission rates. If we're looking at safety, we're looking for individual patients that we avoided individual medication errors. On a population level, we would like to see decreased medication error rates. For service, patient satisfaction versus patient experience. At an individual patient level, we want to see shared decision-making around unnecessary antibiotics. That's an example. Patient comes in with a viral illness and they're requesting antibiotics. Well, certainly antibiotics are not appropriate in that situation. At a population level, we're thinking about antibiotic stewardship and decreased resistance patterns in microbes. If we're looking at cost of care at a patient level, we're looking at the individual cost to the patient, the system, and the insurance for unnecessary testing. At a population level, there is about $750 billion per year in wasted care that could be avoided without negative impact on the patient's overall outcome. So, here's your assignment for your clerkship. Look for examples of PSP in practice on your internal medicine clerkship. Think about it on individual patient encounters. Think about it when you're doing your patient as person interviews. Sometimes Dr. Varney will also do what does it cost sessions with the residents during their noon conference. If he does one of those, by all means, please do attend that. Those examples for PSP in practice and value in healthcare, discuss that with your resident or attending. I suspect that you're going to have conversations about value in healthcare with your attendings fairly frequently over the next 6 weeks. Then when we get to the end of the clerkship, we will have a brown bag feedback session, and then we will reflect on how you can practice PSP concepts in internal medicine in future clerkships, and hopefully use this experience in your own future practice. Okay, that's it. Go out there and improve the value and care of your patients.